This is Dr. Jim Douglas.
You know, some of you are new to me. Of course, Julie's been around a long time, but I really don't know how you administer your soft tissue exams, you know, and I guess I've just kind of taken it for granted that you all know how to do a soft tissue exam. And then I thought, well, maybe we ought to just go over that one time in each of the offices so we're sure that we're on us all on the same plane, okay? Now, I realize that you're probably not going to run into some of these things that we talk about in your whole practicing lifetime. And the reason for that is because in this country alone, there's only about 54,000 oral cancer problems, and only about 13,500 of those die from oral cancer every year. So, you know, your chances in the millions of people that are in this country are pretty slim about even discovering one. But in my long practicing lifetime of 45 years, I've seen some, you know. And we had one here in this office with a soft palate was cancerous. I don't know how he has fared, but he's been under treatment for some time
I
now.
think he's doing very well.
Is he doing pretty well? That's good. Good to hear. I've seen others, and then I've seen numerous cases where we suspected something and sent them off to be treated by somebody else. And some of those I quite admittedly haven't followed up on. So I don't know whether they were cancerous or not, because they came with the problem, went away to a specialist, and after that they kind of disappeared. So anyhow, what we're going to do is we're going to talk about how we should do a thorough exam of the soft tissue. And you might say, well, if I'm never going to see one of these, why should I waste that chair time? But if you save one person's life in a lifetime, in your practicing lifetime, that'll be something really worthwhile. Yeah.
Absolutely.
So what we're going to do is we're going to put the patient back here, and we're just going to go through this as I would do it. Now, you don't have to do it in this same sequence, but I think you need to cover all of the things that I'm going to cover in this, okay? So, I need some gloves here. I don't see any gloves that are...
Those are extra large.
On the bottom.
On the bottom, the lower one is.
Is that extra large?
Yeah, that's for you.
Oh, okay. Thank you. You might want to turn your camera off during some of these lapses here.
I'll edit it.
And do we have 2x2s? Okay, we got a 2x2 here. All right, what I do is I always start in the throat. And then I just kind of work my way forward. So open real wide for me. I push the tongue way down so I can look as far down in the oral pharynx as I can. Now, you're not going to be able to see the larynx, which accounts for some of the cancer that we see every year in this country. But you can see almost there, you know, because we're pushing this thing back and we're looking way down. What are we interested in? We're interested in any bump or lump or open sore or whatever we might find. And we should have something to say about the tonsils in this patient too. You know, so many times in a patient, if the patient has enlarged tonsils, a physician will let that go because, you know, we don't want to take those tonsils out because they think they have a lot of other important things to do with those tonsils, and that's true. But if the patient has a lot of crypts, and you see that yellow pussy-like stuff that's in those crypts, then I think it's up to us to say, we think you need to go and have your tonsils out. Especially if the patient reports to you that, yeah, I have a lot of sore throats. So then you can just order them out. And I used to have an ENT fellow in town here, he no longer practices, but I don't know how many cases I sent to him, but a lot of cases. And he was one of those that, if they have multiple sore throats, just get them out. Don't worry about keeping them for whatever other reasons you might think about. Okay, so now, having looked in there, open for me now, what we're going to do is we're just going to come forward. So stick your tongue out for me. I like to look at the top of the tongue, and of course, you can do open real wide for me. You can depress the tongue, you can look way back on the posterior third of the tongue, okay? And then, open for me, I like to feel the floor of the mouth like this.
Yeah.
Now, what are you looking for in the floor of the mouth? Bumps?
Bumps,
What,
nodules.
if you felt any nodules, what might the patient have in the most serious situation? If you start feeling bumps down here in the lymph
Leukemia?
nodes,
Lymphoma.
lymphoma, what else? The other one kind of associated with lymphoma is leukemia. The patient might have lumps because of that. So, and then the other thing is you want to open for me, please. You want to make sure that the patient doesn't have something going on with swelling in their mandibular.
Retromolar pad.
Well, no, their mandibular salivary gland, which is located right down here, just below the second molar. You go down, kind of deep down here, and if that's swollen, you'll want to report that to the patient and probably follow up with a specialist on that. Okay, so now we've examined the tongue, under the tongue, and now we're going to look in the vestibules, all over, all sides. You always want to look up here, and you might even need a mirror. You might have to go back here with a mirror to push things aside to look, especially if you feel any kind of bump down in this area, okay? So now we've taken care of the oral pharynx, the tongue, the floor of the mouth, the vestibules. Now we're going to go outside and we're going to feel the thyroid. Raise your chin for me here. We want to feel the thyroid. The thyroid's going to be located below this cricoid, I want to say cartilage. It's the cricoid cartilage. It's right here. You want to be down below that. Something I told the group yesterday is that in one case in my lifetime, I couldn't feel a thyroid on a fella, and it had gone below his sternum. That does happen, but it's rather infrequent. So if you're in there and you don't feel anything at all, could be that it's just not very prominent, or it could be that it's escaped you, gone somewhere. But right here on top of the trachea, you shouldn't feel much of anything, because that's where the isthmus of the thyroid is, and it's very thin. Then it goes out, and that two lobes are on each side of the trachea, okay? And now the other thing that I think you should be responsible for is feeling the TMJ, and even these muscles here that close the mandible, the temporalis here, and the masseter here. You want to feel all of those just to make sure there's nothing in them. And open for me. And I think it's a good idea sometimes to feel them like this. And of course, this muscle here, the temporalis, is just one big flat muscle, so you can feel it from the outside. Okay? Then and one of the reasons you want to feel in this area here around the TMJ is you also have the parotid gland here, the other salivary gland that's so large and important to us, It's easy to feel that because it's right here, kind of down below the earlobe, and wraps itself up around the TMJ area. So you want to feel that just to make sure there aren't any lumps or bumps in that, okay?